Welcome to the HFMA Talk podcast, the podcast for NHS Finance. I'm Alex Hunt, Content and Social Media Executive at the HFMA. In this episode, we're bringing you a session from our recent Environmental Sustainability Series event. During the session, Phillip Branford, Environmental and Sustainability Officer at Sheffield's Children's Hospital, outlines the process and impact of the Trust decommissioning its nitrous oxide and pipeline systems. As the first children's hospital in the UK to take this step, the Trust cut its annual carbon emissions by an estimated 4 to 5% and also reduced the carbon footprint of anaesthetic agents by 56%. This work earned the organisation the 2024 HFMA Environmental Sustainability Award, a fantastic example of clinical and finance teams working together to drive meaningful change. Let's hand over to Philip's session.
Introduce myself, Phil Branford from Sheffield Children's. Worked at the Trust for about 5.5 years now, and I lead on all the environmental sustainability works and manage our green plan. So just by way of introduction, I'm going to talk through the project and what we did. I'm not going to talk about it from a clinical point of view because I'm not a clinician. It wouldn't be right for me to do so. And during our award submissions, it was actually our consultant anaesthetist, Dr. Liz Allison, that presented this and was able to give a bit more information, from the clinical point of view of it. But I can talk about the sort of an overview of the project, how we did it, why we did it, what the results are, and why it's, we think, and obviously HFMA must think as well, quite a good project. So there's nothing massively innovative about what we did. In a way, a lot of adult acute trusts have already decommissioned their nitrous manifolds, but we are the first children's to do it, and we'll talk through that a little bit. And as you mentioned as well, alongside decommissioning our nitrous manifold, we've been doing lots of work, or our anaesthetic team have been doing lots of work around reducing volatile gas or volatile anaesthetics as well, and moving over to TIVA, the intravenous anaesthesia, as well. So there's been a couple of things going on, but this is a really good project, I think, also as well as sort of showing how you can push the barriers a bit and challenge what's the norm. Also, really good change management project, and great collaborative working, or a good example of collaborative working as well. So a bit of background, very briefly. Yeah, we're Sheffield Children's, one of only 3 children's trusts in the country. We have an acute hospital, community and mental health as well. So we cover, all areas really. In terms of acute trusts, or foundation trusts, we are relatively small, which always makes me chuckle a bit. Whereas we're a small organisation, we only employ about 4,000 people, which anywhere else would be a massive organisation, but in NHS terms, quite small. And our vision, the trust vision, is to create a healthier future for children and young people, which whether I'm sort of reaching a bit, but I really like that, because I feel like that's, in a way, a good description of what sustainable healthcare is. The World Health Organization, for example, sustainable healthcare, it's ensuring we meet the health needs of the current population without compromising future resources in terms of environmental, economic or social resources. So I sort of feel like for us to do that, for us to make a healthier future for children and young people, basically that is what we're saying in a nutshell. And our aim as well is to be in the top 10 greenest NHS providers in the country, and how we can only really aim or achieve our trust statement, our trust vision, by looking at our services and making them more environmental and looking at what impact we have. The 3 pillars of sustainable healthcare being environmental, economic and social. I thought, especially being on a sort of finance meeting, it'd be important to talk about this a little bit. And I think, especially in the current climate and what's happening with the NHS at the moment, this is vitally important that we remember this and we acknowledge this, and to understand that generally environmental sustainability initiatives will also save us money and generally will make, improve society in one way or another as well. And again, this project, I think, is a perfect example of that. So sustainable healthcare is about understanding that our health and that of the environment around us are intrinsically linked. I often oversimplify things, but how I look at this, and again, very, very relevant for the time being, if we're not a sustainable healthcare service, we are unsustainable. And I think that's the situation we're in at the moment. And if we want to get out of that, we need to look at all 3 of these pillars and not just look at making financial savings without taking the other 2 into consideration, because we'll just removing the problem further down the line, if you like, or causing problems elsewhere. So bit of background about nitrous and its role, as I'm not expecting everyone on this call to know everything about nitrous oxide. I certainly didn't when I started this project, but we'll start with a few alarming facts for a Thursday morning. Why not? Healthcare responsible for about 45% of the UK's carbon footprint, and nitrous accounts for about 2% of the NHS's carbon footprint. Now, worryingly, up to 98% of what we procure of nitrous is wasted, or is assumed to be wasted, which is pretty phenomenal, really. And this is through various things like leaks on manifolds, poor stock management, and theft. It's used as a recreational drug, so there's theft as well involved in that. And going back a little bit further as well, let's go back to school a little bit. Nitrous is a very powerful greenhouse gas, which is again why this is important. They're not wanted to teach you to against, but greenhouse gases, they infrared rays should hit the earth, bounce out, go back out into the atmosphere, leaves us a nice warm temperature. What happens to these greenhouse gases is they form this barrier within the atmosphere and prevent some of these infrared rays from escaping, warms up the planet. That's the greenhouse effect. The warming of the planet in turn creates climate change, and we know that is having impacts on health. So the irony behind this is a drug that we are using in healthcare to help people is actually directly causing harm to our population. So it's sort of a bit of a mad system. So we need to look at alternatives. How can we stop doing this and stop, sort of creating this harm to our planet and our health as well? And in terms of anesthetic gases, they are particularly troublesome. Carbon dioxide has a greenhouse warming potential of, I'm going to say 1. It might be 0. We'll go for 1. Nitrous is almost 300 times more potent than carbon dioxide. So it's a really powerful greenhouse gas. And in terms of nitrous, it persists in the atmosphere as well for 114 years. So it's, again, coming back to what sustainable healthcare is, this isn't just a problem in a year. If we stop using it now, in 114 years time, we will see the benefits from it. So it's a really, it's a really big problem. And the graph on the right-hand side shows the impact of nitrous oxide. So whilst it doesn't have as large a global warming potential as desflurane and isoflurane, the volume that we use means that it has a much, much bigger impact. And that's, again, is why we've looked at nitrous as the first thing to sort of address. Again, just a bit of data, anesthetic gases, and they form 42% of surgical admissions. So they're really, really significant. And almost half of that is nitrous. That's again why we want to do this and why it's imperative that it's looked at. So I said I wasn't going to talk about the clinical use of nitrous, and I'm not very much because, like I say, I don't actually know that much about it. But it's been, especially in paediatrics, it's been a really key component of anesthetics for decades, and it's used in conjunction with other volatile agents. So nitrous is used as sort of the if there is an anaesthetist on this, they might be able to correct me afterwards. But it's sort of used as a starter, if you like. It's odorless and slapping gas, basically. So especially in children, it helps them feel a bit giddy, a bit happy, relaxes them. And then you can bring in the other volatile agents, the isoflurane, the sevoflurane, which have a bit of a taste to them. They can not taste very nice. They can make you feel a bit funny. So that's sort of the role of nitrous. It can also speed up the onset of the other volatile gases and is sort of used as part of that cocktail. However, interestingly, it's not an essential element in terms of it doesn't have any anesthetic properties itself. It's just part of this cocktail. But in pediatrics, it's really, really ingrained. And like I say, in adults, it doesn't seem to be as much so. And anaesthetists are challenging this, however. And alongside, like I mentioned at the beginning around using TIVA, we are looking at alternatives, just how we can reduce our nitrous oxide generally as well. So we use other techniques, distraction techniques, quite a big one. VR has been game changing with our rheumatology team now. We use virtual reality and they've almost wiped out needing to use nitrous or Entonox or anything like that. We use books, we have clowns, we have therapy dogs, all these things that are used just to try and reduce the use of it as well. And like I said, it's not a necessary drug anymore. And a lot of new hospitals aren't even built with nitrous facility, but it's deeply, deeply ingrained in pediatrics. And that was probably one of our biggest challenges that we needed to address is how do we do that? But anyway, the anesthetic gases for us accounts for around 4% of our carbon footprint in our trust, which is sort of standard across the board. So what did we do? I suppose I probably jumped ahead a little bit here, but I was approached, our consultant is Dr. Liz Allison, who's really been the driving force of this project, to say, hey, I really want to do this, but I'm not entirely sure how. We need a bit of help from the sustainability point of view and a bit of funding to do it. Could you help for the try to coordinate it? She could do it from the clinical point of view. So there's a national project called the Nitrous Oxide Project. So we read through all of that and gathered information and guidance. And there's lots of stuff as well at the Royal College. They've got lots of stuff on this. And we started by presenting to our trust board, the Green Board. Liz came along and presented this to us. And then we assembled a multidisciplinary team, which was really, really vital for this. Obviously, our theatres team needed to be involved, myself, our sustainability team, our estates. It was going to impact pharmacy, clinical engineering, and the execs as well. We took it through all our medical gas committees, spoke to our medical director, all these things, because we needed to make sure that all these people understood and were on board with it. And also we wanted to make sure that we didn't have any unforeseen consequences of this outside of our own little spheres as well. So what we did, we collected data on the procurement of how much we purchased and then worked out how much we used. We also surveyed the theatre and anaesthetic teams. We had various questions that we asked them, about their uses of nitrous, whether they thought it's essential. Like we've got an example here. If we were to decommission the manifold, what would be your preference? Would your preference be, let's just get rid of the manifold, we don't need nitrous, let's do it? Or would it be, I'm happy to try and change my approaches, but I still need nitrous there just in case. And I say this is a really, really key part, was engaging with this team at this point to explain why and provide, evidence, data to sort of support it. It's not just me going in and going, hey, let's do this. Here's some clinical evidence for doing it as well. So we presented that all to them. There's an audit tool. Again, this is on the college and the nitrous oxide project. So we used these tools to guide us really. And what we found is we got data from procurement. So this is for a calendar year, but we used almost 500,000 litres, or we purchased, 500,000 litres of nitrous over that time. When we looked at the anaesthetic machines, it's quite crude data. We just looked at usage over a couple of weeks and then multiplied it up. Around 81,000 litres was actually used in theatres. So we actually think this number would have been much lower. So we were quite cautious about it, doing it. But subtract one from the other, we wasted around 83% of the nitrous that we procured, which again is slightly bonkers. What the nitrous oxide project then sort of recommends you do is you survey your manifold, you look at where the leaks are, all this sort of stuff. But however, we decided not to do that. There's lots of evidence from all of the trusts about it. Our initial data, was in the realms of what we expected. Somewhere between 80 and 95% was lost. So we thought, actually, what was the point in surveying all the manifolds, looking at all of that, when we knew what we wanted to do was remove it anyway. So we decided, instead of wasting time and money, let's just press on with the project. But we have this data now to back up what we thought was happening. And we used, I was sort of smile a bit, saying 242 tons of CO2. I'm an environmental scientist. That means very little to me. I don't expect it to mean much to clinicians and other people either. So we always try to use it, convert it over to something that was a bit more meaningful. And for us, it was the equivalent of driving from New York to LA 311 times. But with somewhere between 83 and 95% of those trips were completely wasted and meaningless. We found quite an useful way of putting it into context. So our ultimate aim is to remove nitrous altogether from the hospital, but based on the surveying that we had, for some colleagues it's just too big a step to do. So what we decided to do was this lean strategic approach, where we thought initially what we did was to decommission the manifold, but we would put smaller bottles on the side of the anaesthetic trolleys, so they were available if clinical staff needed them or felt like they wanted them. The added benefit to me of this is, whereas before it was just piped out the wall, this is left my knowledge, just piped out the wall so you can just grab it. Now it's attached to the side of the trolley, but it's locked. So to use it, there's a few more stages involved. You've got to go and get a key, undo the key, plug it in, then use it. So our hope is, alongside the education, and then now being, you have really got to think about, I want to use nitrous, that over time, usage would just drop till we got to a point, we're hoping in about a year, where we can then have the conversation of saying, right, let's now remove it altogether. Or maybe it'd be another stage, another step, right, we'll have it in one place if you think you need it. And so that was the approach we took, which was very welcomed from all. It was all basically accepted within the department. So we got rid of the manifold, and the photo on the right is what it looked like. We've got much smaller bottles. They leak a lot less. And like I said, that's what was accepted very, very willingly by all of our staff. So just a few challenges or more considerations really of what we had to go through. So behaviours and ongoing education, that was really the biggie here, was how do we convince or change people's views when they, with our clinicians, and this is no criticism at all, I'm not an anaesthetist, think that nitrous is an essential part of this, and they needed it to provide care to the children and young people. So how do we start to overcome that? And that was through our engagement, demonstrating evidence base. And the ongoing education is interesting. It's something we didn't really think about at the start, but as we've had new anaesthetists come in from other trusts where this isn't standard, we've started to use a bit more nitrous effectively, because they're not on board with this program or haven't been part of it at the start. So we need to make sure that when we do get new anaesthetists as part of the induction, this is explained to them. There was a cost to the change that we needed to consider. We needed to consider the impact on patient care, which I never would have been. Well, I say never. I probably wouldn't have been approached by an anaesthetist if there was a negative impact on patient care. If there wasn't, they were very confident there wouldn't be, and this wasn't needed because a lot of the anaesthetists weren't using it that much anyway. The thing that I often get asked, and something that we needed to think about, was the environmental impact of removing our manifold. Because what would happen here, the big G-size bottles, if we just removed those and sent them back to BOC, they would have just been opened and vented to air. So we had to try and justify, was that worth, how do we justify that environmental impact of doing that? And what we decided, there was a few things. One, well, about 90% of it was getting vented to air anyway. So there wasn't a huge impact. It was a short-term hit. And after that, it's done. So it would have been worth it over the next however many hundreds of years the trust exists for. But also what we decided to do is actually we would install the bottles on the side of the machine, but we would carry on using the manifold until it had ran right down. So to reduce our environmental impact, it apparently caused chaos because all the alarms went off. There are alarms to say that when the manifold gets low, so they all went off, and we caused chaos in theatres for a day because they couldn't turn them off. But that's what we decided to do. So there would have been a small environmental impact, but we decided it was worth taking that hit for. So in terms of costs, it was only going to cost us about £7,000 to do this work, and it coincided beautifully with the Healthier Futures Fund being set up by Greener NHS, which we applied for. We got the funding we needed. It was just one of those wonderfully timed projects. I was approached by Liz, I think one day, the next day they announced this funding. So it was amazing. So the impact of this change, unsurprisingly, really. So just the carbon impact from our anaesthetic gases, you can see massive reduction, almost a 70% reduction in carbon emissions. I've not yet done the wider trust carbon footprint for 24-25, but about a 70% reduction, I think overall would reduce our carbon footprint by about 3.5% or something like that. But we'll know in a few months when we do that. But it's a significant drop. Costs, I was very frustrated by this. I'm about £80 off our return on investment in 1 year. But yeah, it costs just under £7,000 to cap off the manifold, purchase all the equipment, get it all installed, and we almost saved that over 1 year. However, there are also hidden cost savings. For example, it takes the porters about 20 minutes to replace one of the bottles. They've got to go to the gas store, bring it up, take the old one back down, put an order in for a new one. So that's the replacement of the cylinders. There's maintenance of the manifold. We're talking a few £100s a year. So we haven't sort of gone into greater depth to calculate that, but there's lots of these sort of hidden costs in time, emotion, things like that. So sort of wrap up here, really, our preliminary impact data shows about a 70% reduction in carbon emissions, saves around £7,000 a year, which granted isn't, wild, but we are a very small trust. We've got quite a small theatres department. If you multiply that up for larger trusts, it's significant nonetheless. And it's nice to be able to demonstrate that. But I think the real game changer here, or the real legacy, is inspiring other trusts and helping other groups overcome that barrier. I still have been in meetings quite recently where I presented this, and I've had clinicians say, but you can't do that in children's. I go, well, you can. We have. So that, yeah, you can. And I think that's the real legacy. So Liz Allison, Dr. Liz, she's, like I say, really pushing this and been the force behind this, really. And she's been presenting at conferences actually all across Europe on this and our use of TIVA, which is a really I say it wasn't an innovative project. That is quite innovative in children's. And I think that's really the legacy here. And that's the bit I'm really proud of in here. I'm really proud that we've been able to demonstrate this from a wonderful, sustainable project, but being able to sort of lead the way in this as well, and prove that this is possible. And I think there's something in there, whilst obviously we have to be a bit careful we don't go too wild and cause problems, just to question things and challenge things, how we do stuff. And I'm going to end here. As I say, I'm going to really hammer this home, but I think the quote I always like is sustainable healthcare is good healthcare. And I think this project really, truly highlights that we've hit all three of these barriers, and it is a truly sustainable healthcare project. And it's something that when we're all looking at service improvements and things like that, and like I said, in the current climate, I see as what we're talking about in the NHS at the moment is about sustainability. We use different words. I think the one at the moment, isn't it, modernising? Is that the current slogan? But, if we're talking about reducing waste or making us more lean or improving efficiencies, basically what we're talking about is sustainability and just making sure that we're accounting for all these things and using it as a really good example and how we build a more sustainable NHS, really.
The NHS Finance Event of the Year is back. The HFMA annual conference returns to London this December, bringing NHS finance professionals from across the UK together for 3 days of insight, collaboration and networking. Expect inspiring keynotes from healthcare leaders, engaging panel discussions, and the chance to connect with colleagues to discuss shared challenges and to celebrate the best of NHS finance. Standard ticket rates are now available. Book now to get tickets to the biggest HFMA event of the year. Visit the link in our show notes to find out more and to book. Now, back to the episode.
Any questions? I'd be happy to take them.
Hi there. Thanks, Philip. That was really great. And especially good to see it happening in a children's hospital, because at Gesh, which is St George's, Epsom, St Helier, we've closed the manifolds besides a paediatric dental and maternity. We've got a central destruction unit for maternity, which in itself actually uses quite a lot of energy, but it still reduces the carbon footprint by 90%. So it's still overall a good thing in terms of carbon. But the pushback we get from paediatric dentistry is that the kids just can't do it. Like you're saying, there's that perception that we need it for kids. So I'm just wondering, has there been any kind of measure of the kids' experience, of the patient experience? Are they fine, or are they, having slightly more pain?
I think this is one of the questions I popped down to theatres last week and sort of prepped for this to sort of ask. Yeah, and no negative impact has been noted as such. And again, I've always been hesitant to say about this, but especially moving over to TIVA, one of the things that which isn't quite the question you're asking about, is actually that the recovery rate from that was better. The kids were recovering much better. They weren't feeling as groggy afterwards. But in terms of the volatile anaesthetics, no, there haven't been any negative signs of it. I don't, because we do some dentistry there. So it'd be interesting to know if they got some feedback from what, and whether they still use it for the dentistry things. I don't know. But yeah, we did have some consultants who were just that, it's an essential part of what they did. And interesting what you're saying, Sheffield Teaching Hospitals is exactly the same. They've decommissioned it everywhere apart from, they've got 1 or 2 children's theatres everywhere apart from those 2, because and the strange thing is about it, a lot of our staff work over both sites. So I'm not quite sure why. But
I mean, I guess they're still using it, aren't they, in the smaller bottles? But
potentially some are, but the majority aren't.
I'd be really interested, because I think that's one of the perceptions that I think it's the older anaesthetists that don't want to let go of nitrous because they've used it their entire career and it works. And, so, but the younger crew seem absolutely fine with it. And so I think it would be great if we had some evidence suggesting that actually the patient experience is no worse.
There's something bad because otherwise they wouldn't be able to do it. I'll see what we've got. But it'd be useful, wouldn't it?
Yeah, great.
Has it prompted other ideas from clinicians or departments?
Yes, I think so. I think within theatres, I think quite often actually when I go to clinical sustainability groups, it's quite often anaesthetists that are interested in this. I don't know if it's just because it's come through the college or if it's a bit more of an obvious. They're using a gas; it's quite tangible. Whereas at some other medical procedures, it's not quite as obvious where the environmental impact comes in. So they're often quite keen. They're already keen. But yes, from this, obviously, we're talking about now how we get rid of nitrous altogether, but then also looked at how we can look at reusable items within theatres, so gowns, caps, drapes, and other things. So now we've sort of done this, I've got a bit of a core of keen people that go, right, what are we going to do next? How do we do that? Which is good. But then also, yes, we've just signed up to the Green ED program. And this, I don't know if this is the reason why, because we did a grand round on this, but it's a really good example to be able to use. Because sometimes when I go to clinical departments to say, hey, let's make improvements or do something, and they go, okay, what? And I go, I don't know. Whereas this is now, I've got an example of saying, this is what theatres have done. Yeah, they've looked at, I guess it's maybe you have a medicine that you use a lot of, we could look at alternatives. So it's been really, really useful for that. And it has within theatres, I think. I don't know if I imagine this or whether it's true, but I think sometimes when I approach people, they either assume I'm going to put something a bit complicated in the way, or it's going to be some, green project about recycling and it's going to be a bit of an eye roll. Whereas I've helped demonstrate in theatres that isn't what a sustainability project is. It demonstrates its benefit. I've demonstrated to the management there that it can save you money as well. It's really helped sort of iron out a bit of a pathway moving forwards, which is good.
It's great. Thanks, Philip. I think it does talk to the power of having tangible case studies that you can use to evidence progress and kind of bust a few myths as well and show what exactly is possible. Are there any more questions?
One of the things we find as well is that nitrous is a recreational drug that people use, and one of the questions we were having is, should we be tracking the containers so that we know where they are and if we're losing any, because they actually have a really high street value. I mean, we pay peanuts for it, but actually on the street they're worth 10, 100 times that. So have you guys kind of thought about that or considered that?
It is a major problem, theft of it. And that, I think, we've always just assumed that 90% loss is from the manifold leaking. Maybe there's something more sinister going on. I don't know. So no, we haven't looked at it in any great depth, but I think it probably is something that's, probably does need to be tracked. Because like I say, it's, I think it sort of slips under the radar a bit, doesn't it?
Well, I'd take the opportunity, Philip, to say thank you very much for taking the time to join us. I think, again, from the questions that's prompted, it's been very insightful and very helpful for everyone. And as I say, great to have the case study shared, and hopefully that does provide some inspiration for everyone.
Thank you to Philip for sharing that case study with us. Nominations for the 2025 HFMA Awards are open until the 3rd of October 2025. The awards are a fantastic opportunity to recognise and celebrate the outstanding work happening across NHS finance teams and individuals right across the UK. So, if your team is making a real difference, now's the time to share that story. You can find links to all the details about the awards in the show notes. That's it for this week's episode of HFMA Talk. Don't forget to subscribe so you never miss an episode. If you enjoyed the show, we'd love for you to leave a 5-star rating on your favourite podcast platform. See you next time.